Te whānau e hui hui nei, kia tau te rangi Māori, kia whakatapua tātou me ngā mea e whakapono ana tātou, homi e, hui e, taiki e. That is karakia, giving greetings to everyone here. Let peace be with us, and may we respect each other and what we believe. So my name's Pamela Hale. I'm General Physician here in Nelson and Clinical Director of Medical Services across Nelson Marlborough. And it's my great pleasure today to welcome Dr. Michael Baker as our guest speaker. It's a real privilege to have you, and I'd like to thank you very much. Dr. Baker is a public health specialist and professor at the University of Otago and has a special interest in communicating science to the public. And we all had experience of that during the COVID time, seeing him on the TV regularly and his very clear and concise, trustworthy scientific descriptions, reassuring us all and helping prevent the fear and hysteria that was going on. So on that note, thank you very much, Dr. Baker, and please talk to us.
Yeah, well, kia ora koutou. It is wonderful to be interacting with you as frontline clinicians and other staff who have obviously, like all of us, have lived through a very tough period in New Zealand's history. And I really admire the work that you've had to do on a daily basis, managing your existing workload and also the challenges thrown up by this pandemic. So it's great to be with you, and I'll just switch over to sharing my screen with you.
Yes, we can see that. Thanks.
Yes, and I'll just move over to just a second. So hopefully that's visible.
Yes.
Really, I was asked today to focus on effective public health communication and what we can learn from the pandemic. And obviously, we all have many things we've learned from this experience. So for me, pandemics have changed my life. It's one of the things that actually got me interested in public health. So I used to be a clinician in Auckland, and I was looking around as a registrar, doing a number of runs, and I was looking around at where I would go next. And I was offered a sabbatical in Wellington through an old university friend, actually working in the beehive for a year. And at that stage, it was the tail end of the first phase of the HIV epidemic. And I was asked by the minister to go off and look at how we could minimize transmission of the virus amongst injecting drug users. So I talked to people in the sector and quite a few drug users themselves, and it was obvious that we needed a needle exchange program to make clean injecting equipment accessible. So I worked on that, and it had a lot of support from across Parliament, and I think it reflected the fact that everyone was really scared of this emerging disease. And so, quite surprisingly, New Zealand became the first country in the world to have a national needle exchange program, and that's succeeded in keeping HIV out of injecting drug users, that population. And it just reminded me at the time, wow, actually, having a coordinated response to a pandemic really is very useful. And so I switched over to public health medicine after that and did the specialist training. And I guess, like all of us, our next encounter with the pandemic was SARS in 2003, which I thought was very worrying for a while. And obviously, it's another coronavirus. Really, the pandemic, our first pandemic for some of us of influenza in 2009, obviously was a relatively benign virus, and nothing could really have prepared us for COVID-19. So today, and this is a list of some key points that I want to cover. So it's a long list. It keeps getting longer every time I think about the pandemic. So I'm going to go through a few of these things. My number one lesson is still about the importance of having evidence-informed strategy and equity, and then how we've adapted our response, our communication to different phases of the pandemic. This idea that you do need to communicate to deliver the response and build trust, and the importance of framing how we deal with misinformation, disinformation, how we, in the end, have to protect the messengers, and responding to future threats. So what does it all mean? So just reminding you of these basic concepts. The core idea is epidemic, which is more than expected. So it's just a 3-word definition. You have localized epidemics, outbreaks, and very widespread ones, pandemics. None of these terms are defined precisely. The World Health Organization does not declare a pandemic, it only declares public health emergencies. So just to remind us that pandemics have shaped the world to a huge degree. This looks like a bowling alley, and you can see all these pandemics of the past that were obviously very gruesome. And of course, no one understood them at all, not until, around the 1870s, when the germ theory started to gain ascendance. And prior to that, of course, every theory went because there was no real basis for understanding what was happening. And I often think, well, if a pandemic's coming at you, what do you want to know about it? I think these are the 4 things I think are really important. How transmissible, how severe, how controllable, and how sure are you of the knowledge? And initially, you're not really sure of any of these things particularly. And it is still fascinating that there's still debate about whether something like masks work. And so that rather odd Cochrane review that just came out, which I think really defies logic. So obviously, pandemics, there are many ways of measuring them. We often look at excess deaths, and they are showing that the current pandemic is probably caused, these are data from last year. These estimates haven't been updated, but we're probably looking at least 25 million deaths in the world from COVID-19, at least 4 times more than the numbers that are officially reported, because, of course, to be counted, you have to be tested positive and then die. And so you need other tools for measuring the impact. So one of the things I've noticed is that between pandemics, it's quite hard to get much interest in them. And I don't know how long it will be before people say what pandemic about COVID-19. I think probably quite a long time. This was, I remember, 100 years after the 1918 flu pandemic, trying to get some media interest in 2018 in the centennial of this event. And I went to my son's school, and we got 440 of the boys to lay out in the field to illustrate the peak impact of a pandemic, what it would look like today if you extrapolated from 1918. So it's just the sheer scale of this. There was no media interest at all in that particular event. So just to remind us, if you're trying to conceptualize what can you do with any event like this, you've really only got these 3, the trinity of factors that drive risk in these situations. And that is obviously the organism, which unfortunately we can't do much about. We've got better tools for measuring it. The host factors, which again, we've got limited tools. Obviously, vaccination altering immune status is our main tool there. So it means really pandemic control and controlling many infectious diseases, particularly those that are transmitted through the air. You really look at environmental controls, contact patterns, ventilation, and so on. And just to remind us, again, you don't need to be reminded of this particularly, that this virus is constantly changing. And we now have, of course, a swarm of Omicron subvariants coming at us, including some that have evolved and some that are recombinants. And it's just reminding us that, again, we've got a lot more insights into the organism, but also just its incredible capacity to keep adapting. And then natural selection means that the variants or the genetic variants that thrive will be those that are good at evading immunity or better at being transmitted. So we're now in this period where obviously there's a lot of reassessment of the evidence and what we can learn from the pandemic. So this really brings me to the second point, and I think for me this is still the most important, and that is you have to have a strategy in these for dealing with any health problem. And I think it's great if you have effective science and good political leadership. I think it's a wonderful combination. So I remember early in the pandemic thinking about strategically how should we respond to it, and you really have these stark choices. And with most significant infectious diseases, you're going to try and control the burden, and that means suppressing numbers, which we do for most severe infections, but actually our pandemic plan, and it still is, mitigation. So that's the idea. You can't stop it. It's just going to wash over the country, and you can minimize its harms and avoid it overwhelming the health system. Occasionally, you've got elimination as an option. And of course, we have global strategies for measles and polio elimination, and even eradication can be achieved very occasionally, but I think it's going to become more attainable in the future. And obviously smallpox and SARS are examples. So we probably remember, all of us will remember that on Monday, the 23rd of March, the government committed to an elimination strategy. It didn't want to use that word for a few weeks because it was pretty aspirational. We wrote a strategy, or wrote this in the medical journal at the time, and essentially saying to the public, go home and stay home. At this point was an amazing decision because we had only about 100 cases and no deaths at this point. So this is what we call really good anticipatory policy making. So if we leap ahead, over 3 years, we can look at the impact of that strategy. And what you can see, and this is looking at cumulative COVID-19 deaths per million, and you can see that countries like the US and UK had about 3,000 deaths per million, which is about 0.3% of their population dying from known COVID-19 cases. And of course, it's higher than that in reality. But countries in the Asia-Pacific region took elimination approaches, and these are 4 of the best documented examples. And that meant delaying arrival of the virus and using that time to get high vaccine coverage, and also get much better at managing severely ill people in hospital. And I think a real achievement by our medical staff and our intensivists and nursing staff, so that it's a much more survivable infection than it used to be. So a much better measure of the impact of strategies is cumulative excess mortality. And the reason this is better is that this compares the deaths you're seeing with the numbers you would have seen if you were seeing your normal mortality patterns in the population. And this is showing that New Zealand, remarkably, is still in negative excess death territory right up till recently. And that means that we have had fewer deaths than if we'd not had the pandemic at all. So that is just showing the benefits of not only a good management of the pandemic in New Zealand, but also obviously reducing other causes of mortality over that period. So we know there obviously is huge impacts on the health system. I think one of the best measures, I think, is just simply hospitalizations, because it's a very consistent threshold throughout. And this is showing we really are now, and we've been through 3 really distinctive waves of infection. We may be seeing a very gentle rise now, which is perhaps plateauing at the moment, but a massive additional drain on our healthcare system. So one of the other consequences, of course, is post-infection syndromes of various forms. long COVID and so on. And that this may turn out to be the biggest health impact of the pandemic. So that's just pointing out, I think the second point I want to make is that strategy, I think, is absolutely critical. So a third area, which again will be very familiar to all of you, is just the importance of looking at equity, and particularly across ethnic groups. And this is showing that over a century of pandemics, we've seen consistently higher mortality for Māori compared with non-Māori. And this is really 3 influenza pandemics. But you can see while the inequity has decreased, it's still there. And this is some of the most recent reporting of the differences in hospitalization rates at the top here, mortality rates for Māori and Pacific people, and they're markedly higher than for Asian and European and other New Zealanders. Again, this is very familiar to everyone working in the health system. So one of the drivers, of course, is ethnic differences in delivery of vaccination, and this is showing for Māori and Pacific people lower rates of vaccination and boosting. So again, this is one of those opportunities to do better, and it's clearly one of the pathways that's modifiable. I think we know that the principles and treaty responsibilities and ways of framing those. And again, we have, I think, some great opportunities with Māori-led responses, which we saw during the pandemic. And now with Te Aka Whaiora, we have, I think, we've institutionalized the opportunity for better Māori leadership across the health system. So I think these are really positive developments that, for me, were really reinforced during the time of the pandemic. So one of the things that's always struck me is that we have many different, our society is not homogeneous. We do have some groups who will celebrate the decrease of pandemic controls, which is fully understandable. But for other groups, it's tough, that change, groups who are genuinely very vulnerable to this infection. So another key aspect of the strategy is to keep adapting it to changing conditions. We started with an elimination strategy, which I think served us very well, transition to suppression. You could see us now in a mitigation mode. Personally, I think the evidence suggests that we should be taking, or at least sustaining, our current measures to minimize transmission, that's infection and reinfection. But the challenge is obviously with delivery, that you've got so many different components that you have to do. And this, again, is a massive undertaking for any society, with an elimination strategy, excluding cases, managing outbreaks, preventing transmission in the community, and having a social safety net. So this is a massive activity for any any society at all to manage. And many of you were involved in delivering key components of that. So I'm just going to, I was asked to look at communication, so I'm just commenting on, and I'm going to go through this very quickly, but just the remarkable change in the content of communication as the pandemic progressed. And we remember the early days that still talked about cough hygiene and washing surfaces before we knew better. And then we saw really all we had were what were called, public health and social measures early on. And I think this must be, this branding must be engraved on our consciences now, or consciousness, given it was recurring and I think very effective throughout. And we remember electronic contact tracing to support outbreak and cluster management. And then vaccines arrived, and that became a huge focus. And then, of course, we transitioned to suppression with the traffic light system. And I think obviously quite very assertive measures to promote vaccination. And I think that will be one of the great questions that will be probably needs to be reviewed about, the balance of human rights and public health requirements. And it's always a trade-off. And of course, we saw support finally for mask use. And then the transition from suppression to mitigation. And again, that just a huge shift in the messages that were needed. And now really moving again into this mitigation phase and increasing emphasis on things like getting boosted. Obviously, communication is essential for coordinating action, informing people, and ultimately building trust and collective action, and what we call, the social license that we have. And there's quite a bit of evidence that overall trust in science and evidence has improved during the pandemic. But unfortunately, we're seeing ideas that really are quite contested and probably a more fragmented society over these fundamental issues. So one of the reasons why communication is so effective or so important is if we think about what we're asking people to do, and we can look at this in various ways. And this is the health belief model, which has been around a long time. And I'm just showing it because this is how I think we believe rational people act. It's very much a cognitive model. And it says that people do things if they perceive that they're susceptible, there's severity, there's perceived benefits in acting. This is obviously things like vaccination. They don't see the significant barriers. They see these cues to action, advertising or people around them are saying it's important, and self-efficacy, the belief that they can carry out the action successfully. So these are all elements that are reinforced by people who communicate and governments and so on. And one of the things that we're doing in this space is we've just launched this Public Health Communication Centre. It's entirely independent. It's based at the University of Otago, Wellington. And the reason we can be independent is we're funded by a philanthropist who liked or really appreciated the need for better communication to the public. And so we're very happy to be able to have enough resources to employ 2 staff who can do this indefinitely. So that's unusual, I think, to have those resources. So we've just launched this, and if any of you are interested, you can log on to the site and sign up for a briefing which comes out every once or twice a week with emerging issues. So one of the areas I think is really important with designing media messages is around this idea of framing. And this is one of the framings that we have quite a bit in public health. A public health triumph, nothing happened. And some people talk about the curse of prevention, and that is if you prevent a health problem, the people who have whose lives have been extended or who are living without disabilities are invisible. So they're not marching in the streets saying we want more of this, by comparison with people who feel that they've missed out on something, or healthcare particularly. So I thought there was some really clever messaging or framing during the pandemic, and now, of course, some of it starts to look quite dated and maybe even creates even a negative response to some people because they feel that the reality is different from how it was presented. But certainly, I think there are some key ideas about collective immunity, protecting our community. Maybe that doesn't work it certainly doesn't work with everyone. There's some quite interesting variations on a theme that came out during this period. So one of the things, because I've become at different points a slight mask zealot, only because it seemed to me that was really missing from the government's messaging for a long time. But sometimes when I'm talking about masks and a number of other what you could call pro-social behaviors, is you can think about appealing to the fact that it protects you, yes, it protects other people, yes. So this is the quadrant of things that most people are going to say, well, I may not I may not care about other people, but I care about myself. So that's an incentive for them. Other people hopefully are more pro-social and have a more altruistic motivation, and they can appreciate that masks also protect those around them. And also some of these areas, of course, carry huge legal sanctions. No one would like to expect someone to light up on an aeroplane next to them anymore. We have, when people say to me, oh, we've got to get rid of all these mandates, I say, are you mad? I mean, how do we make driving safe for people? We have a stack of mandates, probably right up to the ceiling in terms of laws, regulations, codes of practice, and so on. So I don't think the question is ever about mandates. I think the question is about where are mandates really required. So another theme in this area of communication, I think, is responding to misinformation, disinformation. And I'm sure all of you do this on a daily basis. Part of the role of healthcare providers, of course, is just dealing with misinformation, the fact that a lot of us don't have all the facts. Disinformation, I find, is quite disturbing because obviously it has that added component of intent. During the parliamentary occupation, it always infuriated me because this person with his sign was always seen to be in camera and talking about natural infection, 99.6% effective. We obviously wasn't reading the New England Journal of Medicine because that same time it came out with evidence saying that actually previous infection was only 56% effective. I think it's probably, that estimate may have gone up a bit. But anyway, this was showing that these kind of events do promote that feeling that, or probably do diminish trust, and I think a lot of mainstream information. So for me, this was probably the high point of the absurdity of disinformation. There was this group who were part of the occupation who had, of course, these foil helmets, and they were saying, they appeared to genuinely believe this, that there was EMR beaming out from the beehive and they had to protect themselves. And they were actually leaving the occupation because they said they'd stripped the local supermarket of aluminium foil and they had no means to protect themselves anymore. So I thought that was pretty remarkable. And of course, you may have seen, well, none of us would watch Counterspin, but it had an interview with Liz Gunn. And she was coughing her way for the interview and had to stop because she actually had COVID-19 infection, although she said it's just a cold at the time. So where does the disinformation come from? Can we turn off the tap? And unfortunately, it's quite tough to do that. And we have obviously some media who are right on the border of disseminating disinformation. We had the Great Barrington Declaration overseas, a local branch, in a sense, COVID Plan B, which went very quiet after a year for a whole lot of reasons, and you can read about it. Some journalists have done a great analysis of that. And we have some political parties that are trying to achieve some political capital by really promoting disinformation. New Zealand Party and Advanced New Zealand, which fortunately in the last election got less than 1% of the votes. And I think that is a statement about the fact that most New Zealanders are relatively literate in these areas. So this is a very busy slide, but I'm just putting it up again. And this is the one I showed before about the health belief model. And it's pointing out, if you look at these domains, we hope that people have absorbed rational messages, that you can look at how misinformation and disinformation systematically erodes all of those ideas. The idea that you're immune to COVID-19 if you have a good diet and wellness, that the pandemic is fake or a mild illness, vaccination is ineffective or worse, is dangerous. There's so much uncertainty and risk of vaccination, it's better to delay it, so that's a barrier. And then cues to action, you're getting the opposite, high exposure to anti-vax messages, and self-efficacy, infection is inevitable, so best to accept the reality. So it only takes one of these messages to really erode support for things like vaccination. It's why it's really challenging when you have this blitzkrieg of disinformation. So the general advice is just keep repeating the messages. And long ago I continued to bore myself by saying these things over and over again, but seemingly you have to. There's the whole issue of fact checking. Generally, the advice is not to publicly disagree with disinformation, because that just becomes an amplifier of that disinformation. And also it links the disinformation to you as a credible source. This was one of my few forays into this area when I had to say to the Herald entertainment reporter that NAS was not a global authority on the pandemic and how to manage it. She was saying, I've had other normal flus which have been 100 times worse. And of course, she made the fatal error, well, it can be fatal, of generalizing from her personal experience to the entire world. And so I just had to point out that actually that's not correct. One of the other themes I think that comes out is protecting the messenger. And I have been, and I think some of you may have also been in the firing line for speaking out on these things. Suddenly you get this really bizarre, counteroffensive from unexpected sources. And suddenly I'm stuck on a billboard put up by Voices for Freedom saying the traffic light system was only designed to nudge people towards vaccination. I really did say that in an interview, but it was hardly the worst thing I've ever said in my life. And really had people scratching their heads. Was that pro-vaccine or anti-vaccine? It was just not clear. I was quite honored to be included, not in the team of 5 million, but the team of 5 tyrants. And also, some of you may be aware of this Cam Slater's hideous blog, which again regularly attacks public health people and others for speaking out on I think, public interest issues. This is a really novel form of attack that really amazed me, and this was a fake account. And they had my photo, they had my name there, and a few other quite unusual comments, and it's actually officially Michael Faker. And they said it's a spoof account. We asked Twitter to take it down, and they wouldn't. And then eventually they did. But one of my colleagues, who's a real whiz on analyzing social media, said, wow, this person was doing 12 tweets per day for all of last year, and started at 5 in the morning, went to 9 p.m. most days. Interestingly, he looked at the weekly cycle for a pattern, and there was just one time when this person wasn't posting tweets, and that was Sunday morning between 9 and 11 a.m. So, I mean, we all had our theories on what that might mean. So this is another person who, I'm just putting this up as I get a lot of threatening emails, and this was just one from the other day. And this person did include their name and details, had sent me a few before, so occasionally I pass them on to the proctor at the university who passes them to the police. This was a person who was actually quite well known to the police down in Christchurch. So they visited him, but and said, look, you need a different turn of phrase if you're going to communicate with people. And of course, this is a criminal offence to threaten people. And anyway, the emails have continued, and his last one is that he's hunting for me in Dunedin, and he knows where I live, and he and his friends are going to come and visit me. So I thought, wow, that's one of the advantages of living in Wellington and working for a university in Dunedin, is that when they come looking for me, they're looking in Dunedin. So this was one that I got the other day that actually created a slight problem, because there is a disinformation project that monitors content on the unmoderated sites like Telegram, and that is a home to a vast array of different groups. Some are fine, some are very antisocial. Anyway, this talk about them invading. I'd agreed to do a talk for the Tawa Rotary Club, and that indicated that might be invaded by some of these groups. And Tawa didn't like the sound of that, so they relocated it to a different, I still went and talked with them, but it no longer became an open meeting. And I've been included with these other people. And it shows how on social media, you can become a bit of a meme for these groups. And Sean Hendy has not done anything in this space for over a year. Susie Wiles is keeping her head down for various reasons. And I've obviously been reducing my content, my comment, because of the pandemic's waning. So this just shows what that maybe we're always going to be current for some of those groups. This was a nicer message from a cartoonist in Auckland when I was raising the problem of COVID Plan B. It just wouldn't be Christmas without fruitcakes, and of course the anti-lockdown people are the fruitcake. So yeah, I thought a picture is so much more effective than anything I could ever say about this. So why do we need to keep refining our approaches in these areas? Well, it's because unfortunately, I think the hazardscape is, if anything, got more dangerous in terms of pandemic threats. And again, using 2x2 tables, which I of course love as an epidemiologist. I know a lot of other health practitioners like them as well. This is from low case fatality to high case fatality, low to high transmissibility. So these are the things we really worry about. Obviously, pandemic flu, and we've got highly pathogenic avian influenza on the horizon. Although it's been there for 20 years, it just seems to be spreading more widely as a zoonotic pathogen at the moment. Smallpox, if it was recreated or delivered, which is quite possible. Emerging disease X covers spillover events from the animal world, and obviously novel synthetic diseases, unfortunately, are a bigger threat as bioweapons, or because far more people have access to gene editing tools now and can be develop psychotic illness, have personality disorders, or be radicalized in all sorts of ways. So unfortunately, this threat is rising. So the other reasons I think we want to keep considering or having these organized approaches in areas such as information is to really promote this reset following the pandemic, a green recovery, a more equitable society. And I think these are hugely important. And just lastly, we all had interesting stories from the pandemic. This was one for me where that whole period around New Zealand adopting the elimination strategy was turned into a play by actually an old friend of mine, Stuart McKenzie, who's a scriptwriter, and Miranda Harcourt. And they used verbatim where they interviewed us, and then they had four actors playing all of us and May Heron. And it was, quite, for me, a very cringy going along to watch that performance. And it was on for a couple of weeks at Bats Theatre in Wellington. So just thinking about what we can take from this, I think my main message is always that we need evidence-informed strategies for not just pandemics, but probably responding to everything in the health area. Equity has a central role. Partnership with communities has to be the way forward. I'm sure I'm speaking to the converted. Communication's critical. Part of it is just to coordinate what is a huge sector, and we know that when we look at Te Whatu Ora, it's possibly one of the largest public agencies in Australasia, I believe. But also, I think for building trust and collective action in the community, I think framing is one of our greatest tools we've got, because the currency we're dealing with is health, well-being, and I think a healthy environment as well, a sustainable environment. And I think that appeals to universal values. And unfortunately, there is a social media particularly does ferment disinformation, misinformation, and I think that's a huge challenge for all of us and also for our agencies. And just want to recognize that I'm working with many other very talented people across New Zealand. and finally a use for the flag debate. Thanks.
Kia ora, Dr. Baker. That was a really enjoyable talk, and some key points I learned about the effective communication strategy with the political leadership combined, and building trust, which was something that was very evident by what you did do, and dealing with the disinformation. I don't know how you manage that. And on behalf of Nelson Marlborough, and in fact all of Aotearoa, thank you very much for your work in that field, which was very much appreciated. And I'm really sorry about the terrible emails and publicity that you have had to suffer, which is just awful. And anyway, you have our full support, well, mine anyway. Now we'll open it for questions. So if you have a question, I'm not sure whether you can put your hand up. Yeah, so if you put your hand up, I'll try and see if I can find you. I guess my first question is, how on earth did you cope with all that?
Yeah, well, I think having supportive family and very supportive colleagues has been fantastic. You just cannot do it on your own. And my department, I was actually head of department here at the start of the pandemic, and then they said, "Oh, I don't think you can be. I don't think you should do that anymore." So I was very happy one of my colleagues took over the job, and yeah, it became fairly all-consuming at different times.
Have you said so much that we have no questions?
I think there's something in the chat.
Yeah, no, that was just saying
Okay.
they agreed with how appalling your emails were.